Hello, and welcome to our course, Calling All First Responders, Real-Time Continuous Glucose Monitoring Awareness in Diabetes Emergencies. We know that first responders care for many people experiencing a diabetes-related emergency. So our goal with this program is to help you understand the challenges of living with diabetes and better understand the reasons behind why these emergency situations occur. We also want to introduce you to Dexcom in real-time continuous glucose monitoring, or RT-CGM, so you can understand how this technology might help people with diabetes to prevent some of those emergency situations. With this new information, if you do encounter a person currently using real-time CGM, we hope you will have a better understanding of how the technology can improve diabetes outcomes. Thank you for joining, and we encourage you to watch all the brief videos. The title of this module is Hyperglycemia Emergencies. Type 1 diabetes is most commonly diagnosed in childhood years. A healthy child can suddenly show signs of being severely ill with symptoms of lethargy, dehydration, nausea, and vomiting, to name a few. Not every child with new onset diabetes presents in DKA, but in some, the early signs of excess thirst, hunger, and urination are short-lived, and within a 24-hour period, the child is ketotic, and EMS is called to transport a critically ill child to the emergency department. I have seen many people in the emergency department in DKA. DKA is a life-threatening complication of diabetes with multiple presenting factors, as shown on the right. As in my scenario that I just presented, around 40% of new type 1 diagnoses present in DKA. There is a larger disparity, with DKA being significantly higher in Black individuals compared to non-Hispanic whites. And with COVID-19, people often delayed seeking care. The severity of DKA based on the presenting pH was worse during the first 6 or so months of the pandemic. So in DKA, symptoms may appear gradually or very quickly. Patients often report an unquenchable thirst and going to the bathroom hourly or new bedwetting. As acidosis develops, fruity breath, abdominal discomfort with or without nausea, vomiting starts, but many people delay treatment because it is often mistaken as the flu. Kussmaul respirations are fast, deep breaths that occur in response to metabolic acidosis. They happen when the body tries to remove carbon dioxide. This can progress to loss of consciousness, seizure, coma, or death. DKA is more common in children. However, adults and older adults can also develop DKA. Here is an example of how quickly someone can develop DKA. A 70-year-old woman with type 1 diabetes eats leftover pasta with clams and feels ill. She starts vomiting and believes she is sick from the food she ate. She goes to bed with a blood glucose in the 200s. Since she has been vomiting, she does not take any bolus insulin for fear of hypoglycemia. She receives basal insulin by pump all night, and in the early morning, she is unarousable. Her glucose is high, and 911 is called. She is transported to a local ED where she spends a few days in the ICU in DKA. Another hypoglycemic emergency is hyperglycemic hyperosmolar state, or HHS. This is a syndrome characterized by severe hyperglycemia, hyperosmolality, and dehydration in the absence of ketoacidosis, and is associated with a higher mortality compared with DKA. Initially, symptoms are very similar to DKA, but usually occurs in people with type 2 diabetes, so individuals may not realize the severity as it progresses. HHS typically leads to severe dehydration, hypotension, and tachycardia, and may progress to loss of consciousness, seizure, coma, or death. All people with type 1 diabetes require insulin. So if there are any reasons why they are not getting enough insulin, it can quickly lead to severe hyperglycemia. As we said initially, those diagnosed at a young age are at increased DKA risk. Hyperglycemic crisis increases progressively in association with A1C levels above 7%. When an A1C is greater than 10%, the risk was 8-fold higher. Individuals with depression or comorbidities such as nephropathy, retinopathy, heart failure, dementia, COPD, cirrhosis, or cancer also have an increased risk. And the social determinants of health, Black and household income of less than $40,000 as well have an increased risk of hyperglycemia. People who experience hypoglycemic crisis or severe hypoglycemia in the previous year were significantly more likely to experience recurrent DKA or HHS. So the 5 I's by Brown and colleague is a nice way to recall the contributing factors to hyperglycemia. The first I is for lack of insulin, perhaps from a pump failure or site that came out or a missed insulin dose. Sometimes at the end of the month, if a person can't afford a copay, they may skip insulin doses. Infections can raise glucose, so I've seen these individuals, often with severe hypoglycemia, have pneumonia or some other infection. An MI or stroke can lead to infarction, which can also independently raise glucose. And meal choices or new meds like steroids can raise glucose. And lastly, pregnancy hormones can contribute to hyperglycemia. Users on the Dexcom can set customizable high alerts at a preferred high level so they can be notified and treat appropriately. The Dexcom Clarity app allows the user to enable weekly push notifications for time and range and patents. The time and range goal for most people is more than 70% between 70 to 180 milligrams per deciliter. And frequent Dexcom Clarity views, so at least 4 times per month, are associated with up to 15% increase in time and range. Overall, DKA and HHS are potentially life-threatening, and Dexcom CGM has proven to lower A1C levels, a measure of average glucose, and DKA events. We thank you for playing an important role in hyperglycemia emergencies and hope this module has made you aware of the benefits of CGM. Our next module reviews emergency scenarios focused on the older adult and frequent 911 calls.